When you're about to go into that room, what's going on in your mind?
I don't think that there's any fear or there's anything like that. I just have to make sure, like, all I do is I have to make sure that my N95 is sealed. And I've found out a way to do that is that because I wear either the visor or I wear my glasses, and I just breathe a little bit heavily. If there's a leak somewhere, then the glass fogs up, so I know that there's a leak somewhere, so I just tighten it up. And as long as it doesn't fog up, I know that that is there.
But what if, man?
Huh?
What if there's a leak? What if there's a leak that you don't see, it's fog up, but there's a leak on the other side of your mask?
It is what it is. I have to take that risk right now.
Have you been in a position in which you have to decide who gets a ventilator and who doesn't?
What we have been doing is, in any kind of normal scenario, if I see some of these patients, they'll be getting intubated on a ventilator very soon. One of the things that we do is we prone them when we intubate them, is we make them lie on their belly, on their face with the ventilator on, and that's been shown to improve mortality in or reduce the chance of death in some ARDS or acute respiratory distress syndrome, which these patients go into. So we make these patients who are not ventilated, who are just awake, we make them lie and sleep on their belly for as long as they can tolerate. And that buys me a few hours. But if I can extubate somebody in that time, remove them from the ventilator, then I have a ventilator, something that's waiting for me for these patients.
First of all, I want to tell you thank you to you and your colleagues, everyone that's there in the city, everybody. Because what I'm trying to do is I'm trying to predict and prepare for what would happen if Houston, goes through what you guys are going through. God forbid it doesn't happen, but you got to be real. So what about your fellows? What's their mind like right now?
I think everybody, if you see our group chats and everything, we're just like, just tell me where to go and we'll go there. And it was no questions asked. Like we didn't have to ask them. They said, we are not going on vacation. This is where we need to be, and this is where we are going to be. There's some light at the end of the tunnel for this soon enough, so we can at least give them something that they deserve.
What is your daily routine? You wake up in the morning, then what?
So I wake up at about between 5:45 a.m. and 6 a.m. I reach the hospital by 6:30, 6:45. 7 o'clock is sign out, I go to my unit. And from there, it's basically from 7 to 7 is supposed to be my shift. We round in the morning with the attending from about 7:30 to depends, 10 o'clock, 11 o'clock, depending on how many patients we have, just to reduce PPE usage and reduce the exposure. Me and my attending, we split up the patients. And he goes into half of them and I go into half of them, or sometimes both of us go into, if it's a challenging patient, then we both of us go in at the same time. And we make the changes to whatever vent setting that need to be made.
When you're about to go into that room, what's going on in your mind?
I don't think that there's any fear or there's anything like that. I just have to make sure, all I do is I have to make sure that my N95 is sealed. And I've found out a way to do that is that because I wear either the visor or I wear my glasses, and I just breathe a little bit heavily. If there's a leak somewhere, then the glass fogs up, so I know that there's a leak somewhere, so I just tighten it up. And as long as it doesn't fog up, I know that is there.
But what if, man?
Huh?
What if there's a leak? What if there's a leak that you don't see, it's fog up, but there's a leak on the other side of your mask?
It is what it is. I have to take that risk right now.
Why?
I'm wearing the visor on top. I'm wearing I double glove.
Burn. Why take that risk?
This is what we signed up to do. If we don't do it, then who's going to do it? These patients are very, very sick, and they need us right now. So this is ICU. This is what real ICU medicine is. But to a level that none of us ever imagined that we'll ever be doing this. Because you normally have 2 or 3 patients like this in your ICU, or 3 or 4. You don't have 29 or 25 of these patients in your ICU at any given point in time.